Thanks for the planning committee for having me. This is a great honor and privilege. It's always hard to follow JT, but I will do my best and talk about the subscapularis repair and reverses, and the evidence is there. So a lot of us here in the audience have a mostly shoulder practice, and I have a practice at a tertiary referral center for the last 17 years. And if you've been at it long enough, then you've seen complications. And when you look at the list of complications after reverse total shoulder arthroplasty, I would argue that very few operations in orthopedics will rival such a high published complication rate. So instability, of course, is the #1 complication that we're worried about. We're also worried about infection and hematoma formation. I did a study with John Sperling back when I was a fellow many years ago, and hematoma is directly associated with periprosthetic joint infection in shoulder arthroplasty. I like to put this slide up with a quote from the Statue of Liberty, because if you have a patient with a complication after reverse total shoulder arthroplasty, you feel like they are tired, they're poor, they're the huddled masses, and wretched refuse, trying to be better, and you're trying to heal them. So when I talk about repairing the subscapularis, the premise for my arguments will be 3 things. The first will be addressing the stability issue. The second is looking at function, range of motion, and I think that in order to understand why we should repair the subscapularis, it's important to understand the biomechanics. And we all want what's best for our patients, and some of us not only want what's best, we definitely won't settle for what's just good or better, but we actually want to be the elite. We want to be the best of the best, and just best may not be good enough. And so I put this slide up because this happens to be a book that I'm reading right now called Die with Zero, but it's analogous to this situation, I feel like, because the old cliche of dying with zero, right, is meaning that you're putting all of your life energy into things that you think are going to pay off long term, and it's not so much about money but time investment. So putting all of your eggs in things that you truly believe in, and when you go to sleep at night or when you die, you have no regrets. So that's the way we should be performing surgery on our patients. And why would we not repair the subscapularis when it's a 5 to 10 minute time investment that will pay off in dividends if you can prevent even 1 or 2 dislocations in your own personal practice? So we published on this, instability after reverse total shoulder arthroplasty. I'll provide about 6 papers looking at instability and how subscapularis repair has been shown to be associated with lower instability rates. About 30% of our patients in this study actually had complex diagnoses like revision surgery, malunion, non-union, etc. But subscapularis repair was definitely found to be associated with a higher stability rate. Also medialized Glenard's designs. This is an older study looking at Brad Edwards. Similarly, they had a complex diagnoses and quite a few revisions and non-unions in their group, but they also found that subscapularis repair was associated with a lower dislocation rate. This is Dr. Friedman's study, and they actually didn't find a statistically different dislocation rate in the subscap repair group, but overall they did have lower dislocations when the subscapularis was repaired, and they had better function in 4 out of the 5 shoulder score metrics. And in terms of internal rotation, we surmise that internal rotation is very important for function, and when you repair the subscapularis, some studies show that you have better internal rotation. Similarly, Dr. Hawkins' study showed a lower dislocation in the subscapularis repair group. And then moving on to biomechanical studies, it has been shown that subscapularis loading will have enhanced stability in all neck shaft angle design humeral prostheses. There's one biomechanical study against subscapularis repair. This is Matt Hansen's study, in that repairing the subscapularis actually which falls below the center of rotation of the deltoid and the posterior superior cuff, but I have yet to see this proven in the literature in a clinical study. So subscapularis in reverse repairs have less instability. This is another paper by Dr. Farmer's group, and they also found that Gromont-style prostheses have a higher dislocation rate. This is also from their study showing why, if you have a Gromont-style prosthesis, the deltoid compression force is less, and therefore it may be more advantageous to repair the subscapularis in this scenario. So in summary, why repair the subscapularis? It has better instability rates. You have better function. The biomechanics are there. I have a clinical case that came to me, actually one of my own patients last month that I did a reverse total shoulder arthroplasty on, presented 1 week post-op with a hematoma, even though we used a drain and TXA. We took him back to the OR to wash him out, and his subscapularis repair was still intact. So we didn't have to change his implants, no poly change. We stayed superficial to the repair and saved him from an explant or a potential paraprosthetic infection. So you have that extra soft tissue coverage there. Why wouldn't you repair it? It's a good time investment, no regrets. And if I had a shoulder replacement, please repair my subscapularis. Thanks.